Today we have with us from the Oregon Health Authority and the Oregon Immunization Program, the Perinatal Hepatitis B Prevention Program staff, Rex Larsen. Rex is a public health manager with the Oregon Immunization Program, and Beth Vorderstrasse is an epidemiologist with the Oregon Immunization Program. Welcome, Rex and Beth.
So excited to go after Dr. Hall. I think he did such a fantastic introduction to the complexity of the ACIP vote and the importance of perinatal hepatitis B vaccination. I'm going to talk about the Oregon Perinatal Hepatitis B Prevention Program. This is sort of a bit more of the nuts and bolts of sort of how in Oregon do we work to screen mothers for hepatitis B and then make sure that they get the case management and treatment necessary, and that their infants get the case management and treatment necessary to prevent cases of hepatitis B in infancy. So I'm Rex Larsen. I'm the Surveillance and Quality Manager with the Immunization Program. And this is really all about protecting newborns from hepatitis B infection. Also, I don't know if Gabriella Escucha and Beth Vorderstrasse are on. They're two epidemiologists with the Oregon Perinatal Hepatitis B program. So if they're on, I don't know if they could turn their video on and wave or something, but there's a fantastic team of folks at OHA. This program really is a partnership between OHA and local health departments. A lot of the work from the program comes at the local public health department level, preventing the vertical transmission of hepatitis B from infected mothers to their newborns. The goal of the program really is to ensure that women receive prenatal screening for hepatitis B infection with every pregnancy, and that all of the cases are reported to local public health authorities. So that involves kind of a complex surveillance system of reporting lab results electronically, as well as reporting screening results on the birth record. So there's a partnership with Oregon Vital Statistics on that birth certificate screening program, as well as the lab results. And then as mothers are identified, those infants receive the hepatitis B vaccine and appropriate treatment after birth. So the goal is to make sure that all stable infants receive the first dose of Hep B and hepatitis B immune globulin within 12 to 24 hours of birth. And that as they complete their vaccination testing, they get tested to make sure that they are immune to hepatitis B, that close contacts receive screening and vaccination, and then also to monitor and improve statewide surveillance indicators. So that would be our birth dose Hep B vaccination rate, screening rates, and other key metrics. And I would love to connect with Dr. Hall. If you want Oregon specific data for modeling, we would be happy to give it to you because we have a lot of data. Overall, the goal is really to prevent chronic hepatitis B and associated complications such as cirrhosis and liver cancer in these infants. So really, what's the risk of hepatitis B infection in infancy? Well, infants born to hepatitis B positive mothers are at risk of acquiring chronic Hep B. The risk of transmission really depends upon the sort of viral load of the mother at the time of birth. The risk is quite high, 70 to 90% if they test positive for high Hep B viral protein. If they test negative for high Hep B viral protein, it's about 5 to 30%. But about 90% of those infants that are infected will go on to develop chronic hepatitis B. And of course, as most of you know, chronic hepatitis B infection leads to cirrhosis, liver cancer. About 25% of chronically infected infants will die later in life from complications from hepatitis B, typically because of liver disease or cancer. And most infected infants are asymptomatic at birth. Often, if there are symptoms, you could see jaundice, fatigue, or abdominal issues later on in life. I think it's also important to note that many infants already have some of these symptoms. So particularly infants born to complex cases, premature infants. So jaundice is not an uncommon thing. So I think the assumption presented during the ACIP meeting was that it is quite easy to identify both mothers at risk for hepatitis B infection and infants at risk for these outcomes. But I think that particularly when you're dealing with complex birth situations and complex patients, it becomes really clear that it is not as easy as we had hoped to identify these patients. So how does the program work? Well, obviously, pregnant individuals are screened for hepatitis B during prenatal care. They test positive, and then they go and receive case management through local public health authorities. So LPHAs track hepatitis B positive cases and their infants. They work with birthing providers throughout the state. That is both birth dose hospitals and small providers. As I said, administer the Hep B immune globulin and the first vaccine within 12 hours of birth, and then complete the vaccine series by 6 months. It really is a large collaboration between LPHAs, healthcare providers, and OHA. A lot of the birth hospitals are really diligent in the state of administering this. And we're working with small providers as well to make sure that they screen and um, report those screening results to OHA as well. And so we're also working with the Vital Statistics Program to hopefully change some of our screening and reporting standards so we can get better data reported on particularly maternal screening. So the program reach, there are about 50 to 80 infants born each year to positive Hep B positive moms. That's the number obviously that gets reported. CDC models significantly more, so between 120 and 180 infants born each year is what the CDC models indicate. I don't think that those models necessarily capture the reality because I think that we're not missing that many Hep B positive moms, but the reality is we know that our screening is imperfect. About 9 in 10 births in Oregon, hospital births in Oregon, get reported screening results. So with that 10% missing results, we know there's going to be some folks that did not get screened. I also think that the people who are most likely to have chronic hepatitis B are more likely to miss screening because they have interrupted prenatal care. So I think it's really important to note that. However, the screening does still, or the program does still maintain really high vaccination rates among at-risk infants, and there have been no cases of documented vertical transmission from mother to child from 2018 to today. So I think the ongoing goals at this point are really to increase community awareness, improve follow-up testing compliance, and improve screening and birth dose Hep B receipt at the state level. Um, I think another big goal, which landed on our plate as of last Friday, is to really respond to these federal changes and reassure people. I think it's much easier to create doubt than it is to assure people of safety. And so I think obviously a lot of communication is going to be needed, a lot of communication by healthcare providers to make sure that people understand that birth dose hepatitis B vaccine is safe and effective. And I was going to talk for quite some time about the impact of the ACIP meeting, but I think Dr. Hall really covered most of that. I think what I would like to reassure everyone is that in Oregon, we are maintaining the recommendation to receive a dose of hepatitis B vaccine at birth. Uh, Past history, as Dr. Thomas said, really has shown that this is the most effective way to ensure that we protect those infants that need to be protected. We have the systems and structures in place to make sure that we maintain coverage. And the goal really is to improve our vaccination rate. Right now, about 80%, I think it's 82% of infants born in the state receive the birth dose of hepatitis B vaccine. I think it's important to improve that. It has dropped a little bit in the past few years post-COVID, and I think our goal should be to work to improve that. I think that's going to be a really high bar now that the ACIP has recommended against this. A lot of the debate that we heard at the ACIP meeting really involved I would say, the difference between an ideal world and the real world. There were a lot of examples about what could be achieved in an ideal world should every pregnant person in the state or in the country get screened. What could be achieved in an ideal world should all things go right during pregnancy. And I think that it's really important to note that public health has never worked in an ideal world. And we really are here to build systems and structures to protect people in the real world. And so I think that passing policy, particularly at the federal level, that relies on the implementation of an ideal world and an ideal healthcare system seems very foolish at this point. And so Oregon does not support the ACIP recommendation, and we stand with the professional organizations, American College of Obstetrics and Gynecologists, and AAP, in continuing to recommend the birth dose of hepatitis B. I think that's really all I have. I think Dr. Hall covered a lot of the other sort of implications around that vote. But if people have burning questions, I think I can answer a couple, but I think if we hold the rest of the questions till the end of the section.